Great. I want to thank the Sachs Associates Group for hosting this forum and for inviting us to talk about multiple myeloma. So my name is Biren Amin. I'm the Managing Director in the Biotech Equity Research Group at Piper Sandler. I'd like to welcome all of our panelists, and maybe Chris, you could start with intros, and then we can just go down the line and do intros before we get into the panel discussion.
Sure. Chris Heery, I'm the Chief Medical Officer at Arcellx. I'm a medical oncologist by background.
Daniel Teper, I'm the founder and CEO of NAYA Therapeutics.
Hi, I'm Nina Shah. I'm the Global Clinical Head for Multiple Myeloma at AstraZeneca and the R&D group.
And I'm Stephanie Oestreich. I'm managing the Myeloma Investment Fund for the Multiple Myeloma Research Foundation.
So maybe a high-level question to start off the panel. I mean, we've clearly come a long way in the treatment for multiple myeloma. I think survival has increased fourfold over the last several decades with advances in new therapies and, cell therapies as well as T-cell engagers and small molecules. So I guess, given where we're at currently with, the current treatment armamentarium, where do you see the current unmet need in patients? Maybe Chris, you could start off, and then we can go to the other panelists.
Yeah, we have a still active treating physician here who could probably tell us better than any of the rest of us. But where I see still a huge need is for patients who have aggressive disease. There's still a real challenge in managing those patients and getting the same sort of outcomes we've seen over the last 20, 25 years, where we've seen the median overall survival improve so dramatically. But there are still patients who have very aggressive disease, and I think because they are treated with the same paradigm as all the other patients, we're probably missing out on an opportunity to have better outcomes.
So I would say that in myeloma, I've seen more progress than a lot of other tumor types. It's not to say that we reach a cure. We're probably still, pretty far from the cure. And patients respond, but they also relapse. They have residual disease, and clearly, Nina can comment more specifically on it. But there's need for options, not only on those patients that relapse after CAR T, but also of earlier stage patients that are now using better therapies. But do we want to maintain those therapies? How long do we want to maintain them? Do you want to wait until they go to CAR T, or are there other options earlier on in the treatment that would get closer to long-term remission?
Yeah, totally agree with everything that's been said. Full disclosure, I'm still a self-proclaimed myelomologist, so I do still see myeloma patients. But I really think this issue of high risk and aggressive disease, especially extramedullary disease, is an unmet need. But where I see the biggest unmet need actually is that we've done so well that all of these patients that are newly diagnosed, you think about it, they're in their 60s, right? So remember, where are we going to be when we're 60? Probably still working, all of these things, enjoying our lives, and they get diagnosed, and now we're committing them to 10 years of therapy. So for me, I think one of the biggest unmet needs is getting time-limited therapy, allowing people to return to quality of life, and getting effective therapies right off the bat so people don't have to be on therapy forever.
Yeah, I would answer this in a three-pronged approach. One is we at the Multiple Myeloma Research Foundation are currently running a trial called Horizon, and it has two arms in one. So we're working with a consortium of academics, KOLs, and also with pharma companies. And in one of the arms, we want to answer the question, what is the right drug for the right patient at the right time? Because now there's so many options that as a physician, you almost have to be like a chess player. You have to think about not just what's the next therapy, what is the therapy after that and after that, because these therapies influence the immune system of the patient, et cetera, et cetera. So determining that algorithm is one point. The other point is a little bit like what Nina was saying. There's precursor diseases, MGUS, and smoldering myeloma. And ideally, you want to prevent the disease from progressing. But right now, we don't really have good algorithms to really stratify them by risk factors. So which ones can you just treat by watch and wait versus which ones are high risk, and which ones can you treat also early on. But for that, you need very safe therapies. So that's the second point. We have done an assessment at our fund. We looked into hundreds of compounds that are being developed in research and development and that are also on the market. And based on that, we have identified 3 areas of priority for our investments. One is novel CAR constructs and also delivery methods like in vivo CAR T. Number 2 is therapies that enhance the immune system of the patient. And number 3 is novel undruggable targets. And this is also what informs our investment thesis. And the last point I want to make here is there's quite some diversity in the treatment of minority patients or patients in academic centers versus patients out in the community. So I would say this is also a big unmet medical need.
Maybe to follow on some of the comments, Nina, you mentioned fixed dose therapy or fixed duration therapy. This is a concept that's actually been gaining steam, at least at this year's ASH. Can you talk about risk benefit of fixed duration therapy versus what we currently have, which is continuous therapy? Because I do agree. I think giving patients lives or patients time back without continuous therapy would be great for quality of life. But is there an argument to be made that we could lose some efficacy as a result?
Yeah, traditionally, all of the clinical trials have shown a benefit for indefinite therapy, for example, with maintenance lenalidomide. Those drugs are older now, and now we have much more effective drugs. So we have to redo that calculation. We have to assess that again. And I think this is a great place for things like cell therapy, which are one-and-done therapies, because people truly can be off therapy. And if you ask any myeloma patient what they want for therapy, they say, "Yeah, I'll take nothing." So that element of quality of life should also factor into our calculation, and as well as financial toxicity. There is a risk that you're leaving something on the table, but we have really good ways to detect disease now in the blood. And so I think that this could be really something that we could move the field forward together.
And then also, I guess, this year's ASH, there was some really critical data sets that were presented. I think specifically the Tec-Dara combo, I think, was one of the highlights for ASH. It was a late breaker on the last day of the meeting. I think, when you look at the data, PFS and OS, I think they achieved around an 83% at 3 months, not at 3 months, at 36 months. And then MRD negativity was, I think, about 2/3 of patients with the combo. So all stat sig. Clearly, groundbreaking data. Maybe I'll start with you, Chris. What are your thoughts on the data, given this combination would potentially be used in the second-line setting?
Yeah, I think the data were really impressive. I don't think any of us should have been too surprised that 2 effective drugs in a group of patients who are otherwise not exposed to those classes of drugs do really well. I think it's probably a bit more impressive than most would have guessed ahead of time. But I think one of the challenges is how to apply the data from Majestic-3, because so many of the patients in the United States will have been exposed to daratumumab in frontline. So that was a population of patients, essentially none of them had exposure to CD38, anti-CD38. So it is a little bit challenging to know how to interpret it and what that's going to mean for second-line patients in the United States and in Western Europe, for instance, where most of those patients will have seen an anti-CD38, at least in induction, but now more and more we're seeing Dara be used in maintenance as well. So, some patients are going to be truly refractory to Dara even in second line. So I think if we had to guess, you would see a significant mitigation of that benefit in patients who've had Dara exposure, but even more in patients who are DARA refractory.
Maybe for the other panelists, if they want to comment on what their impressions were for the data.
So clearly the data is very impressive, and it's not only impressive, it's encouraging, and I think it opens the door to considering other options, because the question is that, is that the second line? Is that eventually a first line? DARA plus T-cell engager, there's I think AbbVie has a trispecific that targets CD38 and BCMA and T cells in a single molecule, which potentially has convenience advantages, but also has some risk associated. We ourselves at NAYA, we're looking at NK engager sequentially with T cell engagers, which also may have some advantages because you have T cell exhaustion in some patients, and you can leverage NK cells, and you can also go to CD38 and BCMA. So there's all of those combinations, which I think are gonna help get to the goal, which is to get patients off therapy for durable periods of time, even before they get to CAR Ts, because not everybody gets to CAR T, and in all due to respect to people that are commercializing CAR T, I think the further we can push the CAR T option, the better for most patients.
Yeah, I actually think this data from Majestic-3, first of all, so exciting to see that for myeloma patients, but it proves something that we have been thinking for the past 8 years, which is that the best therapy against myeloma as it stands is something that involves a T cell. And that's the most effective way right now to get to myeloma cells, even better than high-dose chemotherapy, I would dare to say, in the way that you can get MRD negativity. So I think this is a lot of promise for showing what the immune system can do, even in patients who've already had one prior treatment.
Yeah, and I think what's interesting is also to compare that to the potential of CAR T. So we will have some of the in vivo CAR T trials start in the clinic this year in multiple myeloma. So that will be interesting to compare that to traditional CAR T. But there was a paper with Carvykti that showed that those patients that had functioning T cells could achieve what some of the KOLs are calling a functional cure. So, yeah, as Nina said, the T cells are very important here, but we all know about the difficulties of administering CAR T and managing the side effects, which really can only be done in academic centers. So that's not so much the case with T cell engagers. So I think it's interesting to see how they compete with CAR T.
So on that, I did want to talk about the sequencing of therapy. I mean, Stephanie, you raised a pretty good point there in terms of the sequence of therapy. Clearly, with CAR T, it has so far been concentrated at academic centers, but there's also been a lot of data that suggests that CAR T before T-cell engagers is the right sequence given the T-cell exhaustion. With the TechDARA data, do we worry that if that moves into second line, that CAR T comes after, that we could lose some potency with a CAR T? Chris, you're heavily involved in cell therapy, so as is Nina. So maybe you guys can comment on this question.
Yeah, I mean, I think the data demonstrate that pretty clearly, actually. So one of the things we don't know is if you've had a long break from a T cell engager, can you recover the function of your T cell population so that when you perform the apheresis to make your CAR T, can you get a high quality CAR T product? We don't know the answer to that, although there are some indications in patients who've had longer breaks from T cell engagers in these retrospective analyses, they seem to do a bit better. But one thing we do know for sure is in patients who have come directly off of a bispecific onto a CAR T, those outcomes are significantly worse than in patients who got CAR T after other standard therapeutics as a population. And I think the big question will be not just what is the best PFS 1, but what is sort of PFS 1 plus 2. And another way to say that is what's the best overall survival advantage you can get for a patient. So if we come back to what Nina said earlier, there are some real advantages to trying to use a CAR T earlier. Namely, the T cells will be healthier. That's the starting material from which you're going to make the CAR T. Second, the disease burden tends to be lower, and patients with lower disease burden do really, really well with CAR T. And if ultimately what we're trying to achieve is what patients want, which is a long time off of therapy, that's probably the best mix of things. So again, if patients are diagnosed at 65 or 66, they're not getting younger. They're going to get older and more frail as time goes on. So why not give them the therapy that lets them enjoy their life the most as early as possible?
And give it to them while they're still fit. Yeah, that's the other question. And I think what will also be very interesting is to see some of the clinical data from in vivo CAR T, because there's some theories that because you are basically engaging the patient's own immune system to produce the CAR. You're not just sort of apheresing the patient and then injecting something foreign that the immune system violently reacts to. That this could be a slower and more gentle process, and maybe not exhaust the T cells so much. So that will be an interesting result that is coming out of some of these trials.
Yeah, I think, Chris, I couldn't agree with you more. The PFS 1 plus PFS 2 is so important. And if part of that PFS is treatment-free survival also, that becomes another factor. If you, putting the access issue aside, which I think is a really important issue of access, putting that aside, if you ask any myeloma KOLs, like, what would you give this patient? They always say, I'd rather give CAR T first for all the reasons that Chris said. And if you look at the data, the people that do the best with CAR T if they've had CAR T after something else is the people who had previous CAR T. So that's where you get your highest retreatment, not with the same CAR T, but with different CAR Ts. So I still think there's a lot of a long way for people to go to get the access for these patients. But head to head, I really think that there is room to develop CAR T in the exact same space as this Tec3, which we know it's approved there because of these T cell health issues.
Maybe just a couple more follow-up questions. Can CAR T go into the community setting? Are there, is that realistic in the next 5 years?
Yeah, I think to answer that question, we have to ask, what is community? I think we talk about community as if it's, some single oncologist with a shingle. That's just not the reality. Most community practices are very well organized, large practices, right? So if we talk about where are the majority of patients treated, that they're these very large community practices, which are actually enormous businesses. So what incentivizes a business is profit. And the reality is that those centers have to be able to see that they can make profit. They have to. If they're not going to be able to do this with financially making some money, they're just not going to do it. Now, we are already seeing that essentially every academic institution can be profitable giving CAR T. So the other incentive that would drive that behavior is loss of revenue, right? So if people are choosing to go to the academic institution, let's say, take an example, take Texas Oncology. If people were leaving to go to MD Anderson, they would go, all right, I guess we need to give CAR T. Well, guess what? Texas Oncology has CAR T, right? So they're a community practice, but they're really an enormous, well-funded, and really well-organized practice. So I put that on the side because let's move those to the side, and then let's ask the question more about what about these a tier below that, sort of smaller practices? The answer is yes, but we do have to know which patients are which. We have to know which patients can be managed essentially as an outpatient, not just you can dose them as an outpatient, but you're going to be able to keep them outpatient the whole time with an outpatient clinic where you could give maybe a dose of toci and dex and observe the patient. There are a number of centers around the country that are already doing this, and that model, I think, will be used in more community practices in the future as well.
I mean, I think BMS has done this. They had a study showing that they could give CAR T in community, whatever that means, settings. And I really do think this is possible. I also think that means that there's going to be a lot more bispecifics given in the community as well. So the field is moving. We see what happened with Pembro. Things, people adapt to what is necessary for the patients, and we have to be ready for that.
Yeah, and 2 points here are, if in vivo CAR T really shows better outcomes than traditional CAR T, we don't have to deal with the manufacturing issues, which makes, not just, causes a lot of financial toxicity, but a lot of complexity. And the other theory is that there might be less CRS involved, in some of these in vivo CAR T. We have to see that in the clinical trials, but if that's not as severe and it doesn't require such close management, then it could be very realistic that this can also be administered in the outpatient setting.
Maybe a follow-up. What are the challenges associated with in vivo CAR T? I mean, we saw some early data out of Colonia at ASH. Could we get the durability and the persistence with in vivo CAR T that we've been seeing with autologous?
I guess I'll be the naysayer on this one. I mean, obviously, I'm biased because I work for an autologous CAR T-cell company, so I'll just acknowledge that up front. But there's a reason we haven't started working specifically on in vivo CAR T, and that's because there are at least 3 really important challenges biologically that you need to think through. First is, what is your delivery vessel and how specific is it to the target cell that you want to transduce? So if it's a virus or if it's a lipid nanoparticle, whatever it might be, even if it's 97% specific to where its target is, and if you're giving 10 to the 12th of those particles, you're getting a significant number of those particles into a cell that you didn't mean to. And then the question is, what does that mean? Okay, so that's point 1. Point 2, what happens when those cells are transduced that you didn't mean to transduce? Well, we think it's pretty unlikely that it's going to result in malignant transformation. I'm not really suggesting that. That could happen, but it's pretty unlikely. But more likely is that could be immunogenic. So that transduction of that gene is almost certain, or the delivery vessel that it comes in is almost certainly going to be immunogenic in at least some fraction of patients. How do we know that? We know that because we've tried it with gene therapy in children, and rarely a patient will die. Right? Now, those are deadly diseases with no other options, so it's an understandable risk, and that's a risk that the parents or the person with that disease is taking, and they understand it. But you have to ask yourself, well, if that risk existed with an in vivo CAR T and an ex vivo process CAR T was available, what would people decide? So that's point 2. And then point 3 is actually sort of the opposite of this idea that maybe you'll have less CRS because it's a slower maturing process. The opposite problem is that you can't debulk the tumor in the time period while you're manufacturing the cells, right? So one of the real things we've learned in myeloma is that if you bridge a patient well from when you take the T cells out to when you give them back, if you decrease their tumor burden, those patients have less CRS, they have longer term remissions, et cetera. You won't have that opportunity because if you put the in vivo CAR T in and then try to debulk them with chemotherapy or some other agent, you're going to negatively affect those T cells that you're trying to mature. So those are challenges. They may be able to be overcome. They all need to be solved, and they probably all need to be solved at the same time in 100 patients in a row. And that's going to be, I think, somewhat of a challenge.
Yeah, there's also a question on the transduction efficiency. So we have to see that also in clinical trials. And then for those approaches that are integrating, which most of them are, do we require targeted integration into a safe harbor locus or into the track locus where we have data? Or does it really not matter if it's randomly integrating? And there are some voices that are saying that through random integration, you might have a selection of those sites where you have the highest expression. So it will be really interesting to see, some clinical data here.
Yeah, to come back to the sequencing and particularly of the immune cell engagers prior to CAR T and the challenge of doing CAR T, post T cell engagers. What we've been looking at, and I have to recognize we don't have the clinical data to confirm it, but the hypothesis is that if we started with an NK engager to debulk, followed by a T cell engager with significant less pressures on the T cell, we would probably be in a better immunological situation prior to potentially cell therapy.
Nina, any last thoughts on the in vivo?
Yeah, I think for in vivo CAR, there's a lot of promise for this issue of access, as Stephanie talked about, and there are a lot of unknowns, like Chris said, and I think that we have to be a little bit patient because ultimately we also have to know truly is it as efficacious, and we just don't have the follow-up. Like, it was super exciting to see this data at ASH that somebody, that it started, that this is going somewhere, and I felt like that time in 2017 when we saw these data for CAR at ASH. So it's exciting to see, but we knew we need more time, and like Chris said, if you have the opportunity to have a very effective therapy that's available now, you probably will choose that, but it's going to take time for us to know the full story on in vivo.
So beyond cell therapy and T-cell engagers, Daniel, your company, NAYA, is focused on radioligand therapy in multiple myeloma. Can you maybe talk about its role and maybe want to get the other panelists' thoughts on the potential for radioligand therapy in myeloma?
Sure. When you're looking at radioligand therapy in myeloma, I think the first concern is what are you going to do to the bone marrow? So this is kind of front and center to the thinking that we've done. So, our belief is that, obviously you have to select the patients the right way. So they have to have enough marrow reserve. They shouldn't be the most severe patients, and actually we believe that to focus on consolidation and converting those patients that are responding to first or second line immunotherapy from MRD positive to MRD negative, and if we can do that with just 1 or 2 cycles of short half-life radioligand therapy that's in and out, preserve the bone marrow, is eliminated nicely, then we're likely to have long duration of remission.
Maybe we talk a lot about novel targets. Clearly, in multiple myeloma, the field's been dominated by proteasome inhibitors, by the IMiDs, and then by BCMA targeted therapies. So maybe I'll start with you, Stephanie. What novel targets are you excited about in myeloma? I'm sure you see a lot within the Myeloma Investment Fund. So maybe we could start there and then go down the line.
Mm-hmm. The quote unquote lowest hanging fruit is probably MYC. And the reason is it's a very short half-life protein that's that the cancer cells are addicted to. And I've seen approaches where it's like a bathtub where the water's still running, but you unplug the plug and the water's basically running out, and once you turn off the faucet, then there's no new supply. And you can very, very quickly shut off the cancer cells in that way. So that's an exciting one. Another one is MCL1. Unfortunately, there have been cardiac toxicity issues associated with this one, but if that can be overcome, that's another one that could be a very exciting one. And number 3 is also KRAS. So we've seen approaches there that this target can be made druggable, and there's also companies that are going after this. So those are, probably the top 3.
Of course, we have the GPRC5D. We still are seeing mature data from FCRH5, so we're excited to see where that goes, combining all of those. I still think, I don't know, I'm hopeful still for some sort of checkpoint strategy to work, because I just think, like I said, T cells are great. We make them better. It didn't work out the first time around. I think all of us myeloma immunology wannabes really want to see that work out at some point, but I haven't seen anything so far that's really gone to that distance yet, but I'm hopeful.
Is that a signal that Durva is going to?
No. You're getting me in trouble.
I guess I'll just, I think we covered the top ones. One thing I think is interesting, though, about the signaling molecules that Stephanie mentioned is that what we've seen with T-cell therapeutics is sort of it doesn't matter what the cytogenetics are, and or at least for the most part, seemingly doesn't matter as much as it does with other therapeutic agents. So, for instance, looking at patients with specific mutations, we see essentially the same outcomes with a CAR T, whether that mutation is present or not. Now, granted, there are sometimes confounding issues. If a patient has a specific mutation, they may also have more rapid disease growth, or they may have higher tumor burden, or some of those other things. But if we're matching sort of other demographics, it seems as if CAR T cells, and I think this is why Nina might be mentioning this idea of checkpoint inhibition or other T cell modalities, may be able to overcome those complex signaling pathways through killing with a mechanism that has nothing to do with those signaling pathways.
Daniel, any thoughts on novel targets of interest on your top list?
Not really that, obviously that we're working on, but, the discussion on the checkpoint inhibitors, I'm kind of thinking of the experience that we have in solid tumors with our NK engager of reversing the non-response to checkpoint inhibitors and making cold tumors, hot. So this is, we haven't, looked at all, even from a preclinical standpoint, if that's something that can be translated into hematology and into myeloma. But I think, making sure that checkpoint inhibitors can be, active is probably a low-hanging fruit.
I can just add a comment for the audience in case you're not aware. Checkpoint inhibitors were evaluated in myeloma trials were run between around 2011, 2014, 15, and there was a lot of activity. The problem was that there were also early deaths in a significant proportion of patients who received checkpoint inhibitors. And so the question, and maybe I'm putting words in Nina's mouth, but I think the question all of us probably have now is, could we change that outcome now that we know so much more about how T cells engage with myeloma based on what we've learned from CAR T cells?
Yeah, and then there's also cytokines. So yeah, targeting cytokines as such was unsuccessful in some of the trials, but we have 2 investments into, one is a company that is masking a cytokine, and then it's releasing the mask once the cytokine is moved to the tumor microenvironment, and another company that has a novel type of bispecifics, and they're basically redirecting the cytokine to the tumor microenvironment. So there is emerging knowledge that it's important not just to target a cytokine, but to really bring it to the tumor microenvironment in order to be effective.
Maybe a question for the panel. We talk about some of the novel targets like GPRC5D. Is there a potential for dual targeting approaches? So, maybe I'll start with you, Chris. Arcellx is currently working on a BCMA, CAR T, but in 5 years' time, could we see a BCMA GPRC5D dual targeting program?
Yeah, not giving any guidance about things we might do, but I guess what I'll say is I think the technology already exists to make a dual targeted CAR T. We've already seen one, I guess AstraZeneca has one, and it seems to work, right? It seems to hit both targets. I think the real question is why, and I'm not saying there's not a good why. I'm saying we'd have to think through what the why is and whether that's a good idea or not. So maybe just to put a little more meat on that, if you looked at two different targets, let's say BCMA and GPRC5D, you're increasing the probability that you could clear the last tumor cell if you believe that the reason you didn't clear the last tumor cell is because of the lack of BCMA on that last tumor cell or a mutated version of BCMA or something, right? The reason I'm calling out the why is that the data don't really suggest that's the issue right now. Now, we might find that is the issue in a subset of patients, but in reality, the patients who progress typically retain BCMA, most of them. Now, some of them do have point mutations that may change which epitope can bind, right? So, for instance, that's why I think what Nina was saying earlier, you can get, say, Abecma and then get Carvykti. They're both BCMA targeted, but it works in a pretty significant number of patients to get one after the other. And so the question really becomes, what is the best way to overcome those resistance mechanisms? So I think we'd have to think through all of that and see where does the opportunity exist in the landscape, et cetera. But the last thing I'll say on this is it's not easy to make a CAR product that expresses both CARs equally and has the same efficacy and activity with those CARs. It can be done, obviously, but there are trade-offs to consider. And so when you have one that works really well and hits both targets, you've probably accomplished something, technically challenging.
I mean, we've seen the trispecific data, which is not a CAR, but the trispecific data looking at BCMA and GPRC5D targeting at the same time, and they do appear to increase the response in the naive population, meaning the patients who didn't have prior BCMA and didn't have prior GPRC5D. Those patients look to be responding very well, which suggests that maybe there is some benefit to doing this. However, we're not sure exactly the right modality. We don't know if we want to commit patients to indefinite therapy targeting 2H antigens that are very sensitive or very, very specific for myeloma because you want to maybe save one in your back pocket. And I think that's the sequencing questions we're asking ourselves, like what is going to be the best way to get to the myeloma patients and for the time that we need to get to them.
Yeah, and there's also data from Marcella Moss' group on, basically with a multi-specific CAR. But as was said, we know there's the issue of antigen loss, and the question is that really being tackled best through a CAR or through either a T-cell engager or a multi-specific antibody, or there's also other types of antibodies that I've seen that are targeting many of these antigens.
There's a significant, amount of investment that's being placed into this area, and I think one of the key issues is when we're running frontline or second-line studies, they're requiring several hundred patients with multi-year follow-up. Maybe from a regulatory question, do you see the FDA moving off of PFS or OS as an endpoint and going to MRD negativity as an endpoint? They had an advisory committee meeting last year to talk about it. At our Piper Sandler healthcare conference, we had Vinay Prasad talk about how MRD negative, draft guidance is currently underway. So maybe you want to get your thoughts on that, because I think that's the potential, mover here in this area is if we could go to a shorter endpoint where you don't need as much follow-up.
Yeah, I mean, this ends up being a bit of a philosophical debate, which I'll try to avoid, about what is the role of the regulatory bodies within the United States and Western Europe, for instance. But I do think all the signs indicate we're headed that way, that MRD is a really clear surrogate for progression-free survival. And just to explain that concept, in case anybody's not familiar, when we test for measurable residual disease, we're looking, the validated version is looking at in essentially the same number of gene copies you can find in 100,000 cells. If you don't find a gene copy for your clone, then you say you're MRD negative at that, at that standard. But you can look at 10 to the minus sixth, which is 1 million cells. You can even look at 10 to the minus seventh. And those are better predictors, actually, in our own hands. They're not validated assays, but we know the deeper a patient goes, the longer their benefit tends to be, right? So if you kill more, shockingly, if you kill more cancer cells, patients do better, right? So that all is very logical. And what, just again, for background, this is a 15 to 16 year effort by a bunch of academic clinicians and companies giving funding to show that MRD is a great endpoint. And it is. It's clearly very predictive. I think the ODAC that you were referencing was as positive as it could have been about that endpoint. And I'm glad to hear the guidance is being written, because I think all of us as drug developers would love to know what the target is going to be. It is not clear yet. And I do think there will be, even when that is available, we will still have to show that our drug, when it reaches MRD negativity, ties to progression-free survival. And after that, we'll be able to use MRD alone.
Yeah, I think it's going to go in that direction, like Chris said, because you have very key stakeholders, most importantly the patients, who are asking for this. But to put a group of academicians and pharmaceutical companies together in a joint effort of this many years and as much data as they had and get a unanimous decision from the ODAC really means that scientifically this makes sense for patients with multiple myeloma to use this to quicken drug development, and the patients also want it. So I really think that this is moving in that direction. When it will do that officially, we don't know, but all of the key stakeholders involved really feel that this is the right thing to do for the field and for the patients.
And we believe that this is probably most meaningful for patients in earlier lines. So we believe that this will hopefully encourage more earlier line treatments to be run, which has been difficult because the patients now live so much longer. But with a surrogate endpoint, that will hopefully encourage more companies to run frontline trials.
No, we have strong conviction on the power of MRD. The detection methods are more and more sensitive, and whenever the regulatory authorities are going to move decisively on making it an approval or an approvable, endpoint, I think remains to be seen. But in the meantime, in terms of assessing, different options like those who have been, discussed this afternoon, of which sequencing is better and how do you get patients, particularly in the earlier, stages, to be MRD negative for a long time, and maybe to taper down the treatment or have them completely off treatment, I think is extremely important. This is actually the rationale why we want to bring into the clinic radioligand therapy in earlier patients that are responder to standard of care but are still MRD positive. Because if we can go from, whatever the exact number is, 30 or 40% that are still MRD positive, to as close as possible to zero, I think we're much more likely to have them off therapy for a long time.
Maybe the next question, patients are clearly living longer. We're developing, novel therapies and these are therapies that are used in combination. For example, we talked about Tec-Dara. There's also Talc-Dara that's being developed, and we have CAR-Ts. And when you add it all up, the enormous financial toxicity to the patient potentially, and possibly the healthcare system. We're talking about, at least over a 2-3 year time period, well in excess of $1 million in terms of cost. How do we as a healthcare system afford that? And how does a patient afford that? Maybe this is again a philosophical question. So maybe just your thoughts there. And I guess one other question, the CAR-Ts have, were priced on 2017 levels at $500,000. Are they underpriced? So a couple questions there.
I guess I'll start with that one. Pricing, I'm going to try to dance around a little bit. I think value is really an important way to look at what a therapy provides. Value should be, what are you not spending money on also? And one thing we certainly see with CAR-T is that when patients recover after that first month to 2 months, most of those patients actually improve overall health, not get worse. And so that is a unique attribute of CAR-T relative to almost any other cancer therapeutic you could describe. So that means not being admitted to the hospital for infections, not going back for infusions every 2 to 3 weeks, not going to the parking lot and being frustrated by coming in and out of the infusion facility. So all those things actually add up quite a bit. To answer your first question, though, because I think it's a really good one, there's only really one solution to how that's sustainable, and that's we have to cure some people, right? I mean, the therapeutic landscape in myeloma continues to just expand and expand and expand. And that's just not sustainable. I'm not an economist, but I could tell you, any economist would tell you, like, over time, you will run out of capital, but if you just keep spending more money. So how do we nip that in the bud is, like, some of these patients have to be cured. And I think the good news is we are seeing at least the early signs that is possible. We're seeing, a plateau or a tail on the curve with a single dose of CAR-T in the refractory setting of 30-ish% of patients. That's pretty incredible with cilta-cel. And we think our product can have a tail similar to that as well. If that ends up being the case, then the question becomes, what happens when you get to second line, or what happens when you get to consolidation in first line? Maybe you're talking about 50% or 60% tail at 5 years. And that would really change the landscape considerably.
Yeah, I agree with you, Chris. And I always say, I won't be satisfied until we are like lymphoma, where you can cure more than half the patients after 6 months of therapy with relatively now inexpensive therapy. And I truly think cell therapy has the potential to do this. And it all depends on which cell therapy at what time and how healthy the T cells are and a lot of patient factors. But this is something that I think can address this challenge that we are absolutely going to face if we give endless amounts of combination immunotherapy indefinitely.
Yeah, again, 3 points here. One is, unfortunately, today, because of financial toxicity, we're also not screening, even potential risk populations for precursor diseases. So, but once we have maybe an algorithm, which ones are high risk and which ones should be treated, to prevent therapy or to even prevent progression into full-blown myeloma, that could be very cost-effective. The second point is, could we also develop therapies that are not as costly? And even though our North Star is to help to develop a cure for myeloma, we're increasingly also looking into the costs of the therapy. And there are therapies that are more cost-effective than the current ones. And the third point is, again, to emphasize effective sequencing of therapies. So if you do that optimally, there's also a potential for cost savings here.
We've got about 15 seconds. Any questions from the audience for the panels? Steve?
Please hold for microphone.
Thanks, Biren. What a great panel. I'm going to follow on the excellent question about community hospital treatment for MM. And I want to specifically ask Nina and Stephanie, I think you're going to have fun with this one. My question is somewhat speculative. Hospitals have invested a lot in building out treatment centers using CAR T therapies in particular, and CAR T therapies with, all due respect, autologous backgrounds with often ablation and often complications and hospitalizations, and in vivo CAR T or bispecifics, ADCs, might make some of this or all of it obsolete. So do you think the healthcare system has overinvested in infrastructure to treat patients with multiple myeloma? And how do you see this progressing? Look out 5 years. Do you think there's still going to be so much infrastructure, or do you think this is going to all transition into something much more low impact financially?
I think it's even 5 years. We're still not going to have in vivo data that shows us what we already know about autologous CAR T. So I think there's time, and it's going to take time. So I don't think any of that will be money not well spent. There's also still autologous stem cell transplant, all of these things that are still being done. I really think that there's the right patient for the right therapy. As I always say, there's enough myeloma to go around. And so I do think that some patients will be best suited for those therapies, and other patients may want to get off-the-shelf therapy. You can't forget that these people have to come every month. They have to get IVIG every single time they get a T-cell engager. They have to get prophylactic antimicrobial. I mean, it's a lot. So we have to remember that the day-to-day is also affected for these patients as well.
Yeah, 2 points here. So I think it will be very interesting what we see in the in vivo CAR T data. And yeah, if those are really as effective or even more effective than traditional CAR T, that will definitely make a lot of change. That's also one of the reasons why we haven't invested in any of these local, more cost-effective, et cetera, manufacturing technologies. So I think CDMOs are going to be majorly affected, maybe not in the next, 3 to 5 years, but after that, it's really a question, is that a viable business, in the long term? And the other point is, physicians now have more experience with CRS. There's tocilizumab, and we know much better the early signs of CRS, and we have treatments for that. So it's not as scary as it was, and even for I would say a reasonably experienced hematologist, this is something that can now be that they can now handle.
Great. Want to thank all the panelists. This was a great discussion, and thanks for taking time out of your day, and hopefully you have a good JP Morgan. Thanks, everyone.